I'm going to introduce our next speaker, Dr. Stephanie Wong. Dr. Wong is a pediatric orthopedic surgeon within our department. She's an assistant professor in the department. She's board certified in ortho surgery and has had subspecialty training in sports medicine and hip arthroscopy. She completed her orthopedic surgery residency training here at UCSF, and then she did sports medicine fellowship at Rush University in Chicago. She specializes in arthroscopic treatment of the hip, shoulder, and knee injuries. She serves as co-director for Women Sports Medicine Center at UCSF, and also is the associate fellowship director for our sports medicine and shoulder surgery fellowship. Welcome, Dr. Wong. She's going to be talking to us on hip arthroscopy in the pediatric population.
How are you? So you're right. Oh, that's you, right? You're all set.
Thank you. Thank you so much, Dr. Watkins, for that really kind introduction, and welcome everybody, and thanks for being here today. Today I'm going to talk about hip arthroscopy or hip scopes and when we use them kind of in our pediatric adolescent age patients. So this is my disclosure. I don't think necessarily relevant to this talk. So in terms of when do we do hip arthroscopy, what is hip arthroscopy? So I took, this definition. Arthroscopy really is the origin of two Greek words. So arthro meaning joint, and then scopian, which I'm sure I'm not pronouncing correctly, so Dr. Diab, if he's here, he can help me with that pronunciation later, means to look. So to look inside the joint, right? And how we do that is with this camera. And so, you can see here kind of in this top right-hand corner, kind of our camera has a light cord, and then it has kind of an angled lens so that we can actually look around and we can see around corners, which is actually one of the most technically hard things to do for the hip joint just because it's kind of a really round ball and the socket is really deep. So hip arthroscopy and its use in adults has really been increasing over the past 2 decades. And just for your reference, knee scopes or knee arthroscopy probably started to become popular maybe in the 1970s. Hip arthroscopy, we really didn't figure out how to do until like the early 2000s, just because of the length of instruments we needed as well as the developing traction to actually see within the hip joint was really challenging. So this is kind of more recent development in terms of technology. Pediatric and adolescent hip arthroscopy kind of parallels that increase, but definitely lags behind our applications in the adult population and less evidence overall in the literature. And so I think we have a growing experience with hip arthroscopy as a surgical tool, and I just kind of wanted to walk through some of the reasons why we would do hip arthroscopy. So why would we do hip arthroscopy when open surgery has existed for centuries? So I think these are some of the pros and cons, and this photo here at the bottom is a picture kind of inside the hip joint. This is the femoral head, this is the acetabulum, and this is the labrum here. So one of the biggest benefits is that it's minimally invasive. So we can do a lot through 2 small keyhole incisions that are about 1 centimeter wide. So they're about the width of my pinky, 2 small incisions, about the size of a pencil. Less morbidity, so less soft tissue dissection equals less scar tissue, and then that allows your patients to potentially recover faster and rehab faster. And then I actually think the visualization is actually much better than doing an open surgery. So you can access a lot of the same parts of the joints doing open surgery, but I think the visualization actually is much better with a camera. And we pump in sterile saline into the hip joint to be able to see, and that really gives us a really nice view of the hip. And I'll show you guys some photos and videos of that in a moment. What are the cons of hip arthroscopy? So it's technically demanding. So a lot of sports medicine surgeons don't do hip arthroscopy. It's because it's hard. The learning curve is really steep, and it's much harder to do than knee or shoulder arthroscopy. It's kind of limited to certain areas of the hip. So you'd like to think, hey, you can see everything. I just told you you can see really well. You can see really well, but just parts of the hip. You can't really get to the inferior part of the hip. It's really hard to, you can see, but you can't really access some medial parts or inner parts of the hip joint. And then you do need some special equipment. So you need a special table, which I'll show you some photos of, just to be able to get the hip distraction. And you need a different scope than what we use in the shoulder and the knee. So just some technical differences there. So what conditions can we treat using hip arthroscopy? So these, some of which you've heard kind of from our prior speakers this morning, Dr. Swarup as well as Dr. Ramirez, but definitely hip arthroscopy is most commonly used in the adolescent patient population for femoral acetabular impingement or hip impingement as well as labral tears. You can use it to irrigate a joint or do an irrigation debridement for septic arthritis. You can use it after SCFE or slip capital femoral impingement. So these are patients who had a slip of the femoral, epiphysis at a younger age, and then oftentimes you probably heard from Dr. Swarup this morning that we do what's called in situ screw fixation. We put a screw across to stabilize that fracture essentially of the growth plate, but then they're left with kind of this bump or deformity that's a different type of impingement than FAI. So you can use arthroscopy to address that, and oftentimes those patients also will have labral tears. Perthes disease also is an option, for treatment for, hip arthroscopy. And essentially, Perthes, as you may know, is a condition where the blood supply to the femoral head is altered. So you can use hip arthroscopy to do treatments such as debriding loose cartilage flaps, removing loose bodies, and then if they have any deformity to the femoral head, you can also reshape that. In terms of hip dysplasia, kind of treatment of hip dysplasia, really not in isolation, but as like an adjunct, and I'll talk more about that in a moment, or kind of complementary for some of our open procedures. Some patients, adolescents or kind of young adults may sustain a traumatic hip dislocation. So these are people after a sporting event or maybe after a car accident, they get that dashboard injury, they dislocate their hip. Most of the time they'll have a labral tear, so you can treat that labral tear using arthroscopy. Oftentimes they may chip off a piece of bone as well that we can also remove during arthroscopy. I already said that. For tumor, depending on the pathology, hip arthroscopy can be a useful tool for either biopsy or diagnosis. Typically, I would say for more benign processes. So these include conditions like synovial chondromatosis, which is kind of a cartilage formation, abnormal amount of cartilage formation where basically you have lots of little cartilage bodies all over the hip joint, or pigmented villonodular synovitis, PVNS. You can get that in the hip as well, and I think arthroscopy is a great way to treat some of those benign tumor conditions. Inflammatory arthropathy, so kind of your inflammatory arthritis, not kind of classically used for arthroscopy, but we can obtain kind of like synovial tissue biopsies, which can help our rheumatology colleagues with diagnosing these conditions. And then finally, sometimes extra-articular procedures. So all the previous things I talked about were all things inside the hip joint. You can use arthroscopy right outside the hip joint as well to kind of treat tendons or other structures right nearby, such as the gluteal tendons, hip flexor tendons, et cetera. And so what I wanted to do is talk about some of the most common indications for hip arthroscopy. So a lot of this talk will focus on FAI and labral tears just because that is by and far the most common reason to do hip arthroscopy in this patient population. So I know Dr. Ramirez talked a bit about this, but in terms of femoral acetabular impingement, it really affects a wide range of patients, starting from kind of the adolescent patient up to kind of middle-aged patients. And typically presents as kind of more of a chronic groin pain, less commonly with acute pain. They often don't describe any sort of specific mechanism. So they'll just say, hey, I'm having pain in the groin, or hey, I'm having pain kind of deep in my hip. And in terms of what FAI really is, it's an intra-articular impingement. So you have these kind of repetitive abnormal contacts between the acetabulum and the femoral head-neck junction, as you can kind of see here in this animation. And through that abnormal contact, especially in the adolescent age group, that's kind of where the growth plate ends. So what will happen, well, the body will actually deposit more bone here in the front where that contact is as a result of that chronic stress over time. So you can kind of see how this area looks thicker here at the top. So that's a developmental change. That's not something that they're born with. Actually, if you look at the natural history studies and look at x-rays when they're 11 years old and then get an x-ray again when they're 18 or 20, you actually see this bump develop. So again, a developmental issue. And the problem with that bump is really puts a lot of shear force on the cartilage and labrum. This can lead to labral tearing, cartilage injury, and then eventually you get things like arthritis. And so that's one of the most common, kind of trajectories. So this specifically is referring to those that are familiar with cam impingement. Pincer impingement, where you have an extra deep socket, is a separate pathology, but they can lead to kind of similar symptoms. Now, we refer to patients that have the constellation of both symptoms and imaging findings as having femoral acetabular impingement syndrome. A lot of people may have X-ray findings, and they can have, femoral acetabular impingement findings on X-ray, but to make them clinically relevant or to actually have symptoms, we refer to it as syndrome. And really, the severity of injury really correlates with the time to diagnosis. So a couple interesting things I thought I wanted to ask if you knew, that the average delay from onset of symptoms to diagnosis of this problem is about 3 years. It's a long time. And then patients typically see an average of about 4 providers before any diagnosis and referral to a specialist. So kind of through talks like this, as well as just keeping an eye out, we were hoping to kind of educate some of our primary providers who see most of these patients for musculoskeletal complaints, kind of what to look out for and when to kind of refer. I think what's really interesting is that femoral acetabular impingement is actually really, really highly prevalent in athletes. So we think that those who do sports at a younger age tend to be more prone to developing this condition. If you got X-rays of all the players at the NFL Combine, about 90% of them had at least one sign of FAI. 75% of elite hockey youth athletes with a cam bump, that's a bump on the femur, on their MRI. Really, really common also in soccer players. These are elite soccer players, 72% of males and 50% of females. And then they did this interesting study where they looked at kind of high-level male athletes and compared them to same age group males that didn't play sports, and they're 1.9 to 8 times more likely to have femoral acetabular impingement or cam bump on their X-rays. And so I think that, this is out there, this is common. Not everybody has symptoms from it. So, just be on the lookout. And then talking a little bit more about some of the soft tissue structures. So the hip labrum is a protective ring of fibrocartilage. And this diagram here kind of shows the femoral head removed from the acetabulum. And then you can kind of see this bumper of soft tissue around the acetabulum. So that is the labrum. And its job is to contribute to hip stability as well as the suction seal. And labral tears are really, really common. So present in over 90% of patients in FAI, and they can cause pain as well as mechanical symptoms. They're so common, in fact, that it's actually been suggested in our literature for people who do hip arthroscopy that if you have femoral acetabular impingement on X-rays, you maybe don't even need to get an MRI. I mean, we still get the MRI, but you almost don't need to because you know what it's going to show. And it's going to show this, which is, again, labrum up here with the probe in the labral tear, a flap of cartilage. So remember I talked to you, when you start to get the labral tears, you start to also injure the cartilage. And so this patient, essentially when we're going inside the hip at the time of surgery, we're kind of expecting to see the labral tear. We know what we're going to see. And so why do we care so much about it? I told you it's really common, but most people don't have symptoms from it. What's really, we care about it, especially in our younger patient population, because it's actually one of the most common reasons for early onset hip arthritis in those under age 50. So this X-ray, you can kind of see a bump here. So this patient is a little bit older, in their 40s, but they actually had femoral acetabular impingement signs on their X-rays, and then they subsequently got hip arthritis. And now this hip is, too far gone, unfortunately, to benefit from a hip arthroscopy or hip scope, and this patient's probably going to be talking about a hip replacement at a young age at this point. And so this was an interesting study that came out last year that looked at, and I told you that we've been doing kind of modern hip arthroscopy for 2 decades now. So when we do it early, what happens to those patients in terms of the natural history versus those that have the cam deformities we said, are more likely to develop arthritis. So this was a study at HSS that looked at about 100 patients with 12 years follow-up, which is really, really hard to do. So kudos to them. And they compared the operative side to the asymptomatic opposite hip. And the operative side, they had a relative risk reduction for developing OA on X-rays of about 42%. With the risk factors for OA progression, they found in this study to be patients who had a slightly shallow socket, who were older, had worse arthritis at the time of the scope, and bigger bumps, worse cam impingement. The limitations of the study was that it primarily looked at x-rays, did not really correlate that with the patient-reported outcomes or how the patients were doing clinically. But we do think that modern hip arthroscopy does likely help prevent the development of hip arthritis, at least on the x-rays. In terms of how patients are doing clinically, that's kind of still be determined. In terms of clinical presentation of FAIS, we classically talk about groin pain. So, patients will kind of describe pain kind of in the front or anteriorly. They'll also sometimes show you like this C. They'll say without prompting, they'll say, it hurts like this. Typically they'll say pain worse with sitting, worse with sports and activity. Constant pain or night pain, much less common. They'll sometimes describe kind of mechanical symptoms like hip popping. On exam, which we'll go over at our session with myself and Dr. Ramirez this morning, really limited hip internal rotation compared to the contralateral side, a positive flexion, adduction, and internal rotation test. I like the name of this test because unlike other tests, it actually tells you what you're supposed to do. So flex, adduct, internal rotate. And then scour, which is a test, I'll show you here in this video, but basically kind of like a McMurray's of the hip, but you're kind of sweeping the hip in a circle, trying to catch that labral tear and have it be painful. So this is a video of me doing a fader, and then this is like kind of the scour portion of it where we're kind of sweeping the hip in a circle. And we can practice this during the physical exam session. These patients may also have pain with kind of axial loading of the hip. So if you have them do a straight leg raise, just have them lift their leg straight in the air from the supine position. They'll have pain in the groin. And then a Stinchfield test is kind of resistant straight leg raise. So how do we as orthopedic surgeons diagnose femoral acetabulum impingement? So this was a survey, interesting kind of international survey done, and the most common ways to diagnose FAIS was history of groin pain, 80% of surgeons, and then decreased hip internal rotation. And then here you can kind of see this fader test. So I think, if you just keep these two things in mind, that'll actually clue you in to kind of this pathology. And then I think that, imaging is really important, and because I'm a surgeon, because people are coming to me with conditions such as this, we always get x-rays first. I get them before patients show up, which is actually one of the biggest complaints of our group is that why are you getting x-rays before I even meet you? And I think the reason is because we see pathology like this, we see arthritis, we see this cam bump. So I'd encourage you, for those of you primary care physicians in the audience, if you have someone with groin pain or other musculoskeletal pain not getting better, I would encourage you to check an x-ray. I think it's worthwhile and can really clue you into certain pathologies. So in terms of the x-rays, I like to get two different views, so AP as well as a lateral. This is an AP x-ray here of the right hip showing this cam bump or cam deformity. You can kind of see how there's like a prominence here. And then this is that same patient's MRI. MRI is helpful to show the soft tissues such as the labrum as well as some of the cartilage and other structures. The labrum in cross-section is kind of this triangular shaped structure, and then you can kind of see this is a MRI with arthrogram or with dye injected. And this dye injection does help kind of highlight the labral tears a little bit better, so you can see that dye kind of going between the labral tear and the acetabulum. A lot of the MRIs that I get now are actually without the dye contrast, which is a little bit more comfortable, obviously, for the patients. And I think that the arthrogram does have some role, but most of the time now, especially with the MRI scanners at most kind of modern hospitals, the plain MRI without contrast is usually sufficient to see any labral pathology. So I think non-operative treatment of hip impingement is always indicated both in my adolescent and adult patients, and typically consists of anti-inflammatories, activity modification, as well as a really good structured physical therapy program. A lot of patients with hip pain also have things like low back pain, glute weakness, and difficulty activating their glutes. So I think it's really, really important to get them to a structured PT program. And as mentioned before, it matters that they're actually doing the PT besides going to the PT sessions, because going 30 minutes a couple times probably isn't enough to make a huge difference. And then as Dr. Ramirez mentioned, if there's any question at the diagnosis, if they have pain in multiple areas, groin, lateral, buttock, low back, or if we're just trying to give them some temporary relief so that PT is more effective because their pain is prohibiting them from actually doing the exercises, an intra-articular injection can be really helpful. So how do adolescents typically do if we treat them non-operatively? So this is a study out of San Diego, and actually they showed 82% of adolescent patients with hip impingement did well and had improved outcome scores at 2 years. So 70% of them they were able to manage with physical therapy and rest. 12% of them that were having too much pain to do the PT had a steroid injection along with that. So I think this is a nice number to kind of explain to parents and patients, hey, 82% of people with your condition can get better without surgery. That means, right, 18% of them didn't. They went on to arthroscopic hip surgery. In terms of follow-up, at 5 years, those who were treated non-operatively still had relief of their symptoms. So it's not like, hey, I get better for short term, then I have to have surgery. So I just like to kind of keep this in mind. And then, should we be operating on hip impingement in adolescents, given that so many of them do improve with non-operative treatment? So those who failed non-operative treatment, there are multiple studies now that do support patients do well after hip arthroscopy. They typically have improved function, pain, as well as satisfaction. And this is really interesting. We have very little data on this, but they may have actually better clinical outcomes than adults. The failures seem to be associated, so these are people who had hip arthroscopy, not happy afterwards or can't do their sports afterwards, seem to be associated with female sex, global laxity, so these are patients who have ligamentous laxity, and then a longer duration of time prior to surgery. So remember back to those, that kind of delayed a diagnosis, patients who've had pain for many, many years. So I think this is interesting. I think still more research to be done, but definitely my algorithm is kind of trial of non-operative management for at least several months with a good structured PT program, medications or injection if they need it, and then those who are not better, go ahead and refer them or talk to them, in my practice about surgery, kind of the benefits potentially. And so I wanted to share with you all kind of what surgery looks like. And so the surgery is called hip arthroscopy. So again, looking inside with the camera in the joint, repairing the labrum, and then acetabuloplasty refers to shaving any prominent bone on the the acetabular side. Femoral osteochondroplasty refers to shaving any prominent bone or cartilage on the femur side, and then I typically close up the capsule at the end, and the capsule is a set of ligaments that's just right outside the hip joint. You have to typically go through the capsule to get into the hip. And so this is a diagram here looking at some suture anchors. These are really small devices that are attached to non-absorbable sutures, and the sutures we can loop around the labrum to repair, and I'll show you some images of this in a moment. And this is the typical setup. So like I said, requires some special equipment. This is a special table that we can actually x-ray through, and then their feet are placed in these kind of boots that actually have BOA attachments. So those of you snowboarders in the audience, you know what that is. So actually we use that to actually secure their feet, and then while they're asleep, pull on that limb, and that helps us get the distraction, so actually we can work inside the hip joint. So this is a picture of how we get inside the hip joint. So we actually inject air first, and you see this is a needle here, and then once we inject air and then pull on the hip, again, while the patient's under anesthesia, we can see how there's distraction of the hip, and that's the only way we can actually get in and see inside the joint and do all of our work. And then, these are just some images of how, put the camera into the joint, and then through another small incision, I'll actually be able to, so one incision for the camera, then another incision for all the instruments. And this is kind of what the hip looks like when you first get in there. And I just wanted to share kind of a video of what the inside of a hip looks like. So on the left-hand side, the round ball that looks like the moon, that's the femoral head with some normal cartilage. And then on the right-hand side is the acetabulum. And the acetabulum is interesting. Only part of it is covered with cartilage. You can see here in the center, this is kind of the fovea region. So that's a normal area that does not have cartilage coverage. And then around the perimeter, you'll see the labrum, which is kind of over here on the side, going all the way around. And you can see this patient kind of has a labral tear involving here, and then a little bit back here as well. So this is a different patient's hip. This was a 15-year-old football player who had maybe a year or two of hip pain. It was to the point that he was not able to play his sport because his hip was hurting. We did do a diagnostic lidocaine injection pre-op just to confirm that the hip joint was the cause of his pain, and it did temporarily alleviate his pain, so that was helpful. And then getting inside his hip, you can kind of see here again, labral tear here in the center. This is the repair process. So I've already placed a suture anchor into the acetabulum using a little drill pilot hole, and then the blue and white stitches are what's going to be used to repair the labrum. So now you can see how the labrum is no longer torn or drooping into the hip joint, and then this will stabilize it, protect the cartilage from future injury, and also alleviate his pain. So I do this portion of the surgery while the hip is on traction, and then we put the femoral head back into the acetabulum, and this is a picture of that, again, same 15-year-old football player's hip, kind of a cam deformity or bump here on the side, and then using a burr to kind of smooth out that area of the cam bump. The burr looks really humongous, I tell all the parents, but it's about 5 millimeters, so it's like half the width of my pinky. So it's just really magnified. And then this is kind of after the cam deformity resection, and then you can see the labral tear over here, and then we move the hip under anesthesia, take some x-ray shots just to make sure that the cam bump is no longer bumping up against the labrum and causing the labrum to re-tear in the future, for example. Okay, so in terms of rehab after treatment for hip impingement and after hip arthroscopy, the rehab is long, is what I tell people. I know some people may be familiar with like a knee arthroscopy, meniscus trimming. That's a totally different surgery, okay? So for my patients, usually there are crutches and in a brace for about 3 weeks. We'll protect their range of motion, so kind of let them flex up to 90 degrees, but really protect rotation for a few weeks, again, just to let the capsule and labral repair heal. Physical therapy, I think, is super, super important. So I know there's some physical therapists here in the office, or here in the conference today. But I like them to go at least 1 to 2 times a week, working on range of motion, normalizing their gaits, really focusing on pelvic stability, strengthening their glutes and core, and then kind of doing this progression in terms of running, agility, and then finally sports-specific drills. So running at 3 months and then contact sports or full return to sports no sooner than about 5.5 to 6 months, so that, you know, football player was telling you earlier, he was doing exceedingly well. He and his mom convinced me to let him go back at about 5.5 months, but like 2 weeks early, okay? So, and he was meeting all milestones in terms of strength and agility, et cetera. So this is just a general timeline. Some patients do need longer than this, especially those who have been painful for many, many years, who have a lot of muscle dysfunction or weakness. And then in general, you know, the outcomes after the surgery are really good. So high levels of return to sport, over 90% of patients, almost as many returning to the same level of competition. So they're getting back to doing things at a high level, which I think is great. And then I did want to make a little mention of when we use hip arthroscopy in dysplasia. So I mentioned to you before that we don't usually do hip arthroscopy in patients who have really shallow sockets, just because we're not really addressing the 3-dimensional deformity. But we can use it as an adjunct procedure with some of our other kind of acetabular osteotomies as well. So I think it's a minimally invasive way to treat some of the pathology within the joint, including the labral tears and some cartilage issues. And again, typically combined, and Dr. Diab will be speaking on this in a moment, with a pelvic osteotomy to address that 3-dimensional deformity. Again, no scopes in isolation in those with frank dysplasia, because I mentioned to you pulling the traction or distracting the hip. You try to put it back in, and interestingly, we just had a case of this yesterday, Mohammed and I, where we did a combined surgery, and that patient, her hip, so she's mildly dysplastic, but after the traction portion of the procedure, her hip was sitting like partially out of the joint, no matter what I did. So I was very glad that we had decided as a group, kind of our hip preservation group, to do the osteotomy in that type of patient, because a scope alone actually can make them worse, even though we think we're treating the, you know, the labral tear. It's not really addressing the bony kind of deformity. So what's interesting is the labral tear that patients get in dysplasia is a little different than the one that you get in hip impingement. So hip impingement, bump on the side, bumps up against the labrum and kind of pinches it and then tears it. In hip dysplasia, because the socket is shallow here, the hip is always trying to kind of sublux. And what you get in that case is actually a tear that starts from inside the joint and propagates outwards. So we kind of call this an inside out. This is kind of very detailed, but for nerdy hip people like myself, I think this is kind of interesting. But different etiology, it'll still look like a labral tear on the MRI. And then this is a patient who has a history of hip dysplasia, and her tear is much more subtle, but it's actually on the back side of the labrum. So you can see here how it's kind of lifting up at the cartilage junction. So this is actually a tear, even though you can't see it from the kind of inside of the joint. And then just to kind of wrap things up, I wanted to share kind of an interesting case. This is also a patient that Dr. Diab and I took care of together, but a 16-year-old female figure skater who came to me with bilateral hip pain as a referral from one of my primary care colleagues. And she had these x-rays. So for her right hip, we actually elected to do a combined surgery with both hip arthroscopy, a labral repair, and then an open periacetabular osteotomy. And not to steal any portion of my colleague Dr. Diab's talk, but the periacetabular osteotomy is essentially making cuts here, here, and here, and then rotating the socket over to provide more coverage or to deepen the socket. And that's really oversimplifying it. And then, I did the arthroscopy portion at the time of that surgery as well. So these are her x-rays kind of after, and you can see how this hip, the femoral head is much better covered by the socket now. You see how on this one it's kind of uncovered. So she did really well with that right hip. And then her question to me was, do I really have to have, I'm feeling really good with the right side, but do I really have to have that big surgery on the opposite side? And if you look at her left hip actually looks a little bit better covered, and we have special measurements we'll take. So we decided to do just the hip arthroscopy and the labral repair on her left side. These are some pictures from her left hip. You can see a labral tear here. And then, after the labral repair, and she's about 4 months out from her left hip, Mohammed, just for some follow-up for this one. She's back to ice skating, has no pain in either hip, and is actually quite happy. So I think this is one example of how the decision-making can be a little bit complex, but when we do the right surgeries for the right condition, I think, you can have kind of a happy patient getting back to kind of their sports. So in terms of take-home kind of final thoughts, hip arthroscopy has multiple applications in our pediatric and adolescent patient population, and really helps with our visualization, less invasive. It is technically challenging, so I think it's one thing to consider. And the rehab process is quite involved. The outcomes are typically excellent for those patients, in my opinion, who are indicated well and have femoroacetabular impingement syndrome. But really more research needs to be done on outcomes, specifically in our adolescent population. Most studies are kind of grouping all comers together, and that includes adults, up to age 40s, et cetera. So, yeah, these are my references additionally. And then in case anybody needs my contact, I'm here, and then we're happy to take some questions after Dr. Diab's talk.